I'm Steve Daveluy from Wayne State University here in Detroit, so I also want to welcome everybody to Detroit. As mentioned, I'm going to be talking about some of the emerging therapies to come out down the pipeline, so it's very limited data. I do want to start off by saying everybody in the room knows that HS is very hot right now. There used to be very few publications, a handful every year. Now there's thousands in this year alone. So I apologize in advance if I miss any emerging therapy that someone in the room is working on. I tried to scour the literature, but there's a lot to go through. So we'll start off with ustekinumab, the IL-12 and 23 inhibitor. There's a case series with 3 patients, and there are also 3 separate case reports for 6 patients total. 5 improved, and 1 showed no improvement, which I'm very happy that people are reporting negative outcomes, because I think it's important, and it's a problem in our literature that we don't report when things fail. The dosing was similar to psoriasis, or actually the same as psoriasis, and one of the patients in the case series, they increased the dosing when it wasn't as effective. I forgot to mention too, there is a handout for the talk that should be floating around, so if you have a pile of them and people around you don't have one, try to get it to them. Next in line is secukinumab, as we just heard. It does have some promising activity. It's an IL-17A antibody. So far there have been 2 case reports, both with the psoriasis dosing of 300 milligrams weekly for a month and then switched to monthly. Both patients had resistant disease that had failed other biologics, and they both got a pretty robust response. This is images from the first case. And then this is from the second case, who also failed multiple other medications. And the patients were both very satisfied with the treatment. And then we've heard a little bit about anakinra today, the IL-1 inhibitor. There are some case reports that were conflicting. Some showed improvement, others showed a lack of improvement. And then there was a small case series of 5 patients using 8 weeks of therapy and 8 weeks off therapy that showed some improvement in pain scores and in physician assessment. More recently, there was actually a randomized controlled trial of 19 patients, and they used a different dosing regimen of 12 weeks of therapy and then 12 weeks of follow-up. There weren't any real serious adverse effects, and it looked like it was pretty robust improvement. 78% reached the high score, or the 50% improvement mark. So it looks like there may be some potential with anakinra. Another, here's more data, and they noted that they saw the improvement at 8 weeks of therapy, which, going back to the case series, the therapy was only 8 weeks long. So here, by having the slightly longer therapy, that may be why they saw an improvement. And they did see some maintenance of the results in terms of the time to exacerbation after stopping therapy. It looks like it lasted for about 16 weeks before they started to reach higher flare levels. Another IL-1 inhibitor is an antibody to IL-1B, canakinumab. So far, there are only 3 case reports. 2 improved in their Sartorius score and their pain scores, and 1 failed to respond and actually flared. So kind of mixed results there, which was the same case for anakinra when it was first reported. There were mixed results with the case studies. So as everything in this talk, more study is needed. We need randomized controlled trials to really confirm the results, but hopefully that will be coming down the line. Another medication that we're actually going to be hearing even more about tomorrow is a glucagon-like peptide 1 agonist that is used for diabetes. So it potentiates glucose-dependent insulin secretion, which helps with insulin resistance, glucagon production, and makes patients feel full. It helps with weight loss, and it has some anti-inflammatory effect. So the most common is liraglutide. It has very minimal side effects. There's no risk of hypoglycemia because of the mechanism of action. And it was first noted to improve psoriasis in patients who had psoriasis and diabetes. So they were treating their diabetes but noted that their psoriasis improved, which is sort of a similar story to a lot of the treatments for HS. If there's a drug that overlaps with psoriasis, someone treated a psoriatic, noted their HS improved, and reported the case. In this, they did note a decrease in dermal gamma delta T cells and IL-17 expression, which may be that anti-inflammatory effect that's leading to the improvement in psoriasis. But then in a randomized controlled trial of 20 obese, glucose-tolerant psoriatics, they failed to show a significant improvement. So what about HS? There is a case report of HS improving with liraglutide. It's a 31-year-old female who had failed numerous other therapies before Interestingly, she did not have insulin resistance because in the psoriatic patients without the insulin resistance, it didn't seem like they responded, but in this HS patient, it looks like maybe that's not a factor. So she went from a baseline physician global assessment of a 4 or severe to a 1 or a mild, and during those first 4 weeks, she lost 4.5 kilograms in weight, and then another 4 weeks later, she maintained the response and had an additional weight loss. And the dosing that is listed there is the normal diabetic dosing. You sort of start at a lower dose and titrate up quickly. And then apremilast is a phosphodiesterase 4 inhibitor that's available for psoriasis. There is a case series of 9 patients with HS. 3 dropped out due to side effects, which is also one of the hardships that you face when you're using it for the treatment of psoriasis. It's not always well tolerated. Of the 6 remaining, 5 had significant improvement in their sartorius, their pain, and their DLQI. And they did note that they still had weight loss, nausea, cough, and some reflux. So it's not the easiest to give to patients, but it looks like it may have some data. And it is an oral pill, which can be helpful for the patients who don't want to try an injection. And then, as Dr. Lowe's mentioned yesterday, one of the exciting new areas is complement inhibition. So IFX-1 is an anti-CD5A monoclonal antibody that recently had treatment of 12 patients, and they did weekly dosing, and they saw a high score response at day 50, which was the end of treatment, of about 75%, and then, as she mentioned, continued improvement even off drug to a pretty impressive number of about 80%, which is a really good high score response. And all the patients in the study were early stage 3, so they tend to be more refractory. So very promising at this point, but larger studies, of course, are needed to make sure that it carries on for all patients and applies to more patients than just 12. And then just briefly, I'm mostly focusing on medical therapies because surgical therapies have their own section, but there is some study ongoing and there's some already published about combining biologics and surgery to get better outcomes and decrease the risk of recurrence after surgery. So in this particular study, they gave patients infliximab or ustekinumab 2 to 3 weeks after surgery. They did do primary closure of the surgery, which I'm sure we'll hear a lot about tomorrow, different outcomes when you close or leave it open for secondary intention or graft. So I'm not a big fan of primary closure, but they noted that with the primary closure and the biologics, they did have a significantly lower recurrence rate and a longer disease-free interval of about 18 months, which is pretty significant. And they were only on the biologics for an average of 10 and a half months. So that 18 months was actually after stopping the biologic. They continued to have a longer disease-free interval. And usually after stopping the biologic, it was about 4.5 months before it flared again. And then they had less new involvement as well. So I tried to go quickly because I know we're pretty far behind. So some of the future directions, as I said, more study is needed. Also, we don't know sequential therapy. If a patient fails one agent, do you stay with, if they fail a TNF, do you stay with the TNF? Do you move to one of the others? Are there possibly sort of an area for personalized therapy? Maybe there are some different phenotypes of HS that we're just lumping together. So people may respond better to one medication. Maybe in the future we'll even draw some different biomarker levels and see that will help determine which therapy will be the best therapy for patients. So it's an exciting time for patients because we have these therapies that may be coming down the line, and it's way more exciting than it was years ago when we didn't have much in the way of anything. So thanks very much for your time.